So this is a very usual slide showing that there a pointer showing that patient being underweight, maybe malnourished, have a higher mortality than those patients who are of a normal weight or are obese or overweight. So the issue is to track these patients with underweight, so in a cohort of 16,000 patients. There is a new definition published and proposed by the ESPEN, so European Society of Nutrition, for the terminology of clinical nutrition, including malnutrition or undernutrition. We will see that both can be used. For patients at risk of malnutrition, they can develop overt malnutrition as a result of several conditions, including acute disease or injury-related malnutrition, which is typically the case of critically ill patients. Now, if we look at the in the textbook, again, the basics of clinical nutrition published by ESPEN, what is malnutrition? It's a state, from a physiological standpoint, it's a state resulting from the lack of uptake or intake of nutrition, leading to altered body composition, either decreased fat-free mass and body cell mass, leading to diminished physical and mental function and impaired clinical outcome from disease. So there is a lack of uptake or intake of nutrients, leading to functional impairments. In terms of a clinical definition, we can rely on this American definition, which defines malnutrition as a prolonged decrease of energy intake associated with weight loss and some physical findings, such as loss of subcutaneous mass, muscle loss, or fluid accumulation, or reduced muscular strength, reduced hand grip strength, in fact. The ESPEN wanted to refine and to redefine the diagnostic criteria for malnutrition for the purpose of being an update in the ICD-10, so the official classification of diseases. And so there was an expert panel. They first voted on the terminology. You can see that malnutrition and undernutrition were proposed, and malnutrition was preferred by a slight majority of voters. Now, the diagnostic criteria for malnutrition were rediscussed during this panel meeting, and you can see that the black bars are the winners. So weight loss, BMI, so body mass index, and fat-free mass index. The fat mass index, the food intake, the appetite, the biochemical tests, such as albumin or prealbumin, very popular in France, for instance, were not voted by these experts. So we will keep for the definition of malnutrition only weight loss, BMI, and fat-free mass index. So they use these criteria, and they suggest a decision tree for the diagnostic of malnutrition. So the new official definition of malnutrition, there should be a risk of malnutrition associated with either a BMI below 18.5 or 21 if patients are older than 70, or a weight loss of at least 10% combined with either a BMI below 20 or a fat-free mass index below 15 or 17 according to the sex. Now, if we go back to the ICU, we look at the new recommendations from the the American Society of Critical Care Medicine and the American Society of Parenteral and Enteral Nutrition, published in 2016, so very new guidelines published less than 1 year ago. One of the questions was, does the use of a nutrition risk indicator identify patients who will most likely benefit from nutrition therapy? And based on an expert consensus, implying that there is no robust evidence, they suggest a determination of nutrition risk, for instance, using a nutritional risk score or a Nutric score, I will show you both in the next slides, to be performed on all patients admitted to the ICU for whom volitional intake is anticipated to be insufficient. High nutrition risk, I will identify those patients most likely to benefit from early enteral nutrition therapy. So in other words, this panel of experts recommends to use a score to assess the nutritional status in critically ill patients. So we have the nutrition risk score, NRS 2002, and Nutric and Pandora, which are two. I will just allude to these three scores. So a nutrition risk and a nutritional status score. Nutritional risk score is very simple. Is BMI below 20? Has the patient lost weight within the last 3 months? Is there a reduced dietary intake? Is the patient severely ill? And if any of these questions has a positive answer, then we move to the second step, which will qualify for the level of risk. And any patient in an ICU will have an Apache 2 score above 10, and will then have, by definition, the highest risk of malnutrition. Now, the Nutric score, developed by Darren Hyland in Canada and co-workers, is based on the coexistence of chronic inflammation, chronic starvation linked to the chronic disease associated with an acute episode, which itself is associated with acute starvation and inflammation. This will lead to micronutrient deficiencies, erosion of the lean body mass, and ultimately immune dysfunction leading to high mortality. So the Nutric score was validated on a cohort of patients, but you can see that the components of the Nutric score are not nutritional at all. The age, the Apache 2 score, the SOFA score, the number of comorbidities, the days from hospital to ICU admission, either below 1 or more than 1, and the IL-6 level. IL-6 was chosen as an inflammatory marker. And then, using these combinations of variables, there was a calculation with a 0.0 to 5, meaning a low malnutrition score, a low Nutric score, 6 to 10, a high score associated with worse outcome. Indeed, they found, and this is not surprising at all, that the sicker the patient, the higher the mortality by deciles. And also they found, and this is a proof of concept in the view of the authors, that those patients having a high score, more than 6, had a decreased mortality which was proportional to the % of caloric prescription received. This did not hold true for the patient with a low Nutric score. So this was interpreted as a predictor of need for nutrition. The Pandora score, which comes from Europe, from Michael Ismayer in Austria, was also recently published in PLOS ONE. And in this score, age, BMI, and also functional aspects were used to calculate the score. So can you walk? What did you eat today? Main patient group admitted, either internal medicine, surgery, geriatrics, neurology, or others. Is there a cancer, and which is the fluid status? So this is a combination of some nutritional aspects, so like body BMI, functional aspects, and again, the higher the score, the higher the mortality, which was used to confirm in the development sample and in the validation sample. There is no version of the Pandora score for the ICU until now. So, does nutritional status matter in the ICU? Yes, definitely yes. During the acute phase, to avoid excess caloric intake and to minimize the risk of refeeding syndrome, Michael Cazard will allude later in this session to the refeeding syndrome. And during the late phase, after the first few days, to provide an adequate provision of calories and proteins just to match the expenditure and the losses of proteins. So we know that during the acute phase, which is this one, so we have a low or relatively low energy expenditure, mostly carbohydrates as fuel. And we know that, as Michael Cazard did, a sub-study of the e-panic trial, giving much calories by the parenteral route was associated with the deposition of fat into the muscles, which was also associated with dysfunction of the muscles. And there was a proportionality between the amount of calories and the delta femoral muscle attenuations, the deposition of fat into the muscles. In a recent Australian trial, Gordon Doig and his group showed that in patients who experienced a low or decrease in phosphorus during the first days after initiation of artificial nutrition, they divided the group either in usual care or intervention. This is related to the issue of refeeding syndrome, and they considered that having a low phosphate or decrease in phosphate while initiating nutrition was a warning sign for refeeding syndrome. So they divided the groups, the patients into two groups. They randomized the patients, 339 patients. I'm sure that Michael will show this data again. So the point is that the red group received much more, the standard care received much more calories than the blue group. And you can see that the amount of calorie was similar in both groups only after 6 days. And importantly enough, as the groups were well balanced for the other characteristics, the hospital discharge status, the day 60 and day 90 mortality were all better in the group who was managed with less calories while phosphorus decreased, so that the patient with refeeding syndrome. Now, during the late phase, does nutritional status matter in the ICU? Yes, of course, to provide an adequate provision of calories and proteins. Or can we check that we are improving and we are restoring muscle mass and strength? We can use anthropometric measures such as the phase angle, which is obtained by dividing the resistance by the reactance when we do a bioimpedance, which is really easy to perform at the bedside. It takes about 2 minutes to get a value in a patient. And we showed in this large trial of about 900 patients in Europe and South America that there was a good predictive value of this phase angle, so a reflection of the fat-free mass on the 28-day mortality. We may also use CT scans to assess the muscle mass using the L3, the muscle at the level of the third lumbar vertebra, and we can deduct the total muscle mass of the body. And we have definitions for low muscle mass below 110 square centimeter in females and 170 in males, associated with an increased mortality, as shown by Peter Weiss in Amsterdam after adjustment for the confounding factors. And we also did a functional assessment. Several other people did, but I have these data available. So we did a functional assessment, which is complementary to the assessment of the muscle mass of the MRC, the Medical Research Council score, and also the hand grip test and the 6-minute walk test. These are just examples of functional tests that we can use to check whether our physical therapy associated with the amount of calories and proteins given to the patient is sufficient to preserve muscle function. So does nutritional status matter in the ICU? Yes, during the acute phase to avoid excess caloric intakes and the deleterious effects, at least at the level of the muscle as shown in the e-panic trial, to minimize the risks of refeeding syndrome, and during the late phase to promote the restoration of muscle mass and strength in association, of course, with physical activity. With that, I close and I invite you in Brussels for the third metabolic and course on metabolic and nutritional issues in the ICU in May 2017. Thank you for your attention.